In this presentation, we will be reviewing nutrition for the diseases of the kidneys. Our kidneys play a very vital role in maintaining chemical homeostasis in the body. Without our kidneys, we're not able to process components within our blood to maintain the fluid electrolyte and acid base balance that is required. The kidneys eliminate these wastes in the urine, and each kidney has approximately 1 million microscopic nephrons. And sometimes these nephrons are referred to as workhorses because they're responsible for filtering, reabsorbing essential blood constituents. They are responsible to secrete ions to maintain the acid base balance. They excrete fluid and other substances as urine. However, don't forget that the kidney also has important functions such as the responsibility to manufacture hormones, which helps to regulate blood pressure. Think about the hormone renin. It also helps to stimulate the production of red blood cells through the hormone erythropoietin. Our kidneys regulate calcium and phosphorus metabolism in the final steps of vitamin D synthesis. Also, our kidney is responsible to help detoxify our body from certain drugs and toxic waste. Don't forget that our kidneys filter about 1 liter of blood every minute to remove any excess fluid and also more than 200 waste products from our body. The vital metabolic and hormonal functions of our body are also performed by the kidneys. Now, think about all the different responsibilities we've just discussed and the many roles that the kidneys play in a patient's overall wellness. So, if there's kidney disease, there are going to be some serious consequences. Therefore, the nutritional needs of patients with kidney disease can be very complex and demanding because the kidneys are associated to many of the systems in our body function. Look at the picture in the textbook, figure 18.1. This is a picture of one of the million nephrons in our kidneys. You can see that blood flows into the glomerulus, and then some of the fluid is absorbed into the tubule. Then the waste products are going to be filtered and passed through into the bladder. The fluid and the dissolved substances needed by the body will then be reabsorbed in vessels alongside the tubule. And this is showing how the kidney can filter waste products. Nephrotic syndrome is a complex series of symptoms that occurs when there's damage to the capillary walls of the glomerulus. And this glomerular damage is going to then result in increased urinary excretion of protein or proteinuria, also leads to decreased serum levels of albumin, which we refer to as hypoalbuminemia, and can lead to edema. And nephrotic syndrome often is a result from primary glomerular disease or glomerulonephritis. It can also be secondary to the accumulation of this waxy starch-like glycoprotein, amyloidosis. Glomerular disease can also be secondary to diabetes, infection, or systemic lupus erythematosus, SLE. Any type of chronic inflammatory disease can also affect the glomerular apparatus. Now, treating nephrotic syndrome includes addressing first the underlying cause, as well as, because we're talking about the kidneys, we need to take measures to reduce high blood pressure, edema, high cholesterol, and infection. And I want you to think about this as we determine the nutritional therapies. We also then need to think about how to decrease urinary albumin losses, or this protein loss, proteinuria. We need to prevent protein malnutrition, therefore muscle catabolism. We need to help supply adequate energy throughout the body and slow the progression of renal disease overall. So patients with nephrotic syndrome will need to consume an adequate amount of protein, and it's important to understand the value or the formula that is needed. Your patient with nephrotic syndrome needs a minimum of 1 gram per kilogram every day. The energy needs overall, they need at least 35 kilocalories per kilo per day. Otherwise, you are at risk for malnutrition from the catabolism of the lean body tissue. So, what are good sources of proteins that you would recommend to a patient with nephrotic syndrome? Lean meats, well trimmed poultry. You are limiting eggs to about 2 a week. Sources of protein can include fish, shellfish, beans, and nuts if there are no other contraindications. Additionally, patients with nephrotic syndrome need complex carbohydrates such as fruits and vegetables. And this should actually be the basis of their diet because the protein needs to be limited. Now, if a patient additionally needs a gluten-free diet, this would actually help improve their symptoms clinically. This would enable a reduction or actually a discontinuation of steroid dosages. And in this gluten-free diet, wheat, rye, and barley would be restricted. We also need to think about any hidden sources of salt in their medications, in their food, oral hygiene products. Did you know that toothpaste and mouthwash often contain a significant amount of sodium? And so, though most patients know not to swallow these products, sometimes it happens. So, instruct your patient not to swallow them. Elevated lipids can be a problem as well. So, you're promoting the use of healthy oils like olive oil, coconut oil. You want to limit the use of whole fat dairy products and avoid any type of partially hydrogenated oils that can be found in fast food and processed foods. So, anything that would be considered a trans fat. High dietary sodium is detrimental to the nephron because this extra sodium needs to be limited to control edema and hypertension. You will have to encourage your patient to be on a low sodium diet. So anything processed or with a substantial amount of sodium, which is about anything processed, should be looked at very carefully. So think of things like cheese, anything that comes from a can, dried pasta, rice. All of these things should be controlled and limited. The next handful of slides, we'll be reviewing acute renal failure, which remember, acute meaning abrupt, an abrupt loss of renal function that may or not be accompanied by oliguria or anuria, which is the decrease or the loss of urine production. And the most common cause of acute renal failure is either acute tubular necrosis or ATN, which is an injury after there is a lowered blood supply in the body, or if there's some type of nephrotoxic disease process that's occurring. This can happen with certain medications. We're going to talk about the 3 phases of acute renal failure. Now, though few patients do not experience any reduction in urine output, some will experience this, And these are the three phases. So the first one will happen within the first 24 to 48 hours after the injury. And this is called oliguric phase. This phase can last 1 to 3 weeks. During this time, there is a retention of excessive amounts of nitrogenous components in your blood, causing acidosis, high serum potassium, phosphorus levels. You will see hypertension, anorexia, edema, and there's always a risk of water intoxication, which you'll note if you're seeing low sodium levels in your patient. Sometimes you'll see some of these symptoms, and sometimes you'll see all of them. The next phase then is the diuretic phase. And just like the name suggests, urinary output is going to be then gradually increased as the kidneys start to diurese. And this usually lasts about 2 to 3 weeks. Then, 3 to 12 months after that initial insult comes the recovery phase. Your kidney function gradually improves, but there could be some residual and permanent damage during this phase. Your important nursing interventions are thinking about the intake and output of your patient. During the oliguric phase, fluids need to be restricted to the amount of the patient's output. So when we're talking about output, we're not just talking about urine, but any type of vomitus or diarrhea as well. So whatever that output is, your book says that you're going to add 500 mLs to that. This is during the oliguric phase. Now, during the diuretic phase, there are large amounts of fluid that may be needed because now you're starting to diurese and you need to replace those losses. So you're also closely monitoring your eyes and nose then as well. Now, during this time, constipation could be a problem because of that previously restricted intake of fluids. And fresh fruits, like those that are high in potassium, bed rest, and sometimes just the effects of medication, all could contribute to constipation. So, because of this, there are complex nutritional guidelines that involve a reduction in protein, sodium, potassium, phosphorus, and fluid intake. So, one more time, reduced protein, sodium, potassium, phosphorus, and fluid intake. You also want to continue the avoidance of highly processed foods, fast foods, and convenience type foods as well, because they will have a high amount of sodium. Before addressing the nutritional therapy of patients with acute renal failure, you have to consider the cause. Patients may be hypermetabolic if renal failure was caused by trauma, a burn, septicemia, or other type of infection. And so during this time, you might have some changes to a patient's appetite, which then would increase the risk for rapid nutritional decline. You're suggesting in these cases that at least 30 to 40 kilocalories per kilogram are going to be from non-protein sources. And this is going to help with weight maintenance overall and to meet the extra demands of their initial insult. Again, remember, trauma, burns, infection. Fats, oils, simple carbs, and low protein starches are also given during this time. If dialysis is required for treatment, then the recommendation is 0.6 to 0.8 grams of protein per kilograms of body weight. If dialysis is used as part of the treatment, the protein intake can be liberalized a little bit more to 1 to 1.4 grams per kilo. Regardless of the situation, high quality proteins need to be recommended. Milk, eggs, meat, poultry, and fish. If you have a diet containing less than 60 grams a day of protein, this may lead to a deficiency in niacin, riboflavin, thiamine, calcium, iron, vitamin B12, and zinc. And these are all nutrients that are necessary for rebuilding and healing the body. And then these may need to be supplement during the convalescent phase or as the patient is recovering from acute renal failure. Your textbook says that diets that are not controlled for phosphorus, potassium, and protein energy malnutrition are associated with greater risk for bone disease and heart disease. What happens if you have too much phosphorus? This can disrupt the hormonal regulation of phosphate, calcium, and vitamin D in your body. High phosphorus and calcium levels also can lead to dangerous calcium deposits within your blood vessels, your lungs, your heart, your eyes, and this could therefore lead to increased risk of cardiovascular disease, heart attack, stroke, and even death. Nutritional therapy during the oliguric phase needs to require a restriction of sodium to 1,000 to 2,000 milligrams per day. We are also restricting potassium to 1,000 milligrams per day. Now, both sodium and potassium are principal electrolytes, and these may be lost during the diuretic phase and even during dialysis. And if this occurs, then we need to replace those loss. And depending on the urinary volume, the serum levels of these electrolytes, and the frequency of dialysis, your water intake will be controlled. Now we're moving on to chronic kidney disease, used to be called chronic renal failure. Now, CKD involves a progressive, irreversible loss of kidney function, and this can happen over days, months, and even years. The common causes of chronic kidney disease are glomerulonephritis, nephrosclerosis, which is the necrosis of the renal arterioles. This is caused by hypertension. Chronic kidney disease can be caused by obstructive disorders. Think of things that are obstructing the pathway of the kidneys: kidney stones, tumors, any type of congenital birth defect, and of the kidneys specifically, and any type of urinary tract obstruction. Diabetes, lupus, and illicit use of street drugs or other analgesics can also insult the kidney, causing chronic kidney disease. But regardless of what caused the kidney disease, what occurs is this retention of nitrogenous waste products and fluid and electrolyte imbalances. And we know that these imbalances will affect all the body systems. So then, what is the goal to use before end-stage renal disease? Primarily, we want to slow the progression. We know that it may be coming, but we can take measures to reduce the complications and slow the progression. So during this end-stage renal disease, or ESRD, we are trying to reduce uremia through conservative management. We may try hemodialysis, peritoneal dialysis, and less conservative management would be renal transplantation. So you might be asking, how can we slow this progression? There are medications that can be used, like beta blockers, renin-angiotensin blockers. We can use diuretics, statins, and even aspirin are very helpful pharmacological treatments in the early stages of chronic kidney disease. Before dialysis is required, the focus is making sure that we will minimize these complications. But at some point, the kidneys may not be able to filter out the toxic waste. So we need to reduce uremia by removing this waste. And this is when hemodialysis and the other types of dialysis are recommended. The medical nutritional therapy is a legal term that is regulated actually by the federal government, and this allows our Medicare recipients to then qualify for nutritional counseling and get a qualified renal dietitian. And this term, pre-end stage renal disease, will help them to achieve these things. The reason why is, again, prevention of the progression and the need for dialysis, slowing down any complications. Now, ideally, everybody at risk for renal failure should be given personalized nutrition as well as a dietitian and advice a year before dialysis is needed. If you are able to have a renal dietitian, they will evaluate the results of your labs, especially those in the renal panel: BUN or blood urea nitrogen levels, creatinine, sodium, potassium, phosphorus, and glucose. The next step then is to determine current versus the ideal intakes of fluid, energy or calories, protein levels, lipid, phosphorus, potassium, sodium, vitamin, and mineral levels from each meal. Remembering that not every one patient is the same, their nutritional management is really going to depend on the treatment that they have overall, in addition to any type of medical and nutritional status changes of that patient. These dietary modifications need to start as early as possible, and we want to try to individualize this as early as possible. And the reason why is we're trying to minimize, again, the uremic toxicity, because the increased toxicity will progress renal disease. And remember, our goal is to delay this progression. We're also going to try to prevent wasting and malnutrition of our patient. So we are limiting foods from metabolic byproducts and providing sufficient amount of calories to prevent this type of catabolism from occurring. So it's important to provide the appropriate food combinations that the patient will actually eat and enjoy, as well as maintaining the appropriate levels to slow down their kidney disease. It seems very complicated, and it is. And this is why we have a renal dietitian specialist. They're credentialed as board certified specialists in renal nutrition. And these nutritionalists are vital to the overall care of the patient. If you are looking especially for proteins, we are trying to find high biologic value proteins. These are the preferences for protein sources. Now, some protein foods in vegan diets have a very low biologic value. Now, think of patients that are vegetarian or they're reduce lactose and they're vegetarian. These diets include high biologic value protein sources, but they tend to be high in phosphorus, so careful planning will then be required. Many times patients find a renal diet to be very difficult to follow for long-term periods. These patients need a lot of support and motivation and encouragement. So your job is vital to helping patients maintain their nutritional status, their weight, but also we need to help with their morale. Yet, we know that we don't have specific renal training. We have, and we're expected to have a broad understanding of what patients will need to include or limit in their diet. Now, at this point, you might be wondering what is meant by high biologic value proteins. Sometimes we refer to these as HBVs. And these are any type of protein sources that are going to have all of the essential amino acids, very proportionate to what we need and what the requirement is for our body. And so these proteins are going to be those primarily from animal-based sources such as dairy products, eggs, meat, poultry, and even fish. And with CKD, the guidelines do recommend that at least 50% of your total protein are going to come from these sources. And so this is why you see that having plant-based proteins um, sometimes can be a little bit more difficult to figure out because the animal proteins are the ones that are going to contain a complete essential amino acid profile. However, there are some new studies, and I encourage you to look for these studies, that plant-based proteins can offer kidney protective benefits as well, slowing the toxic effects of chronic kidney disease. But again, overall, you're trying to find proteins that have the complete essential amino acids. I mentioned hemodialysis earlier in the presentation. However, let's just review what hemodialysis is. And this is a procedure where we are trying to remove blood, and it's shunted out of the patient's body. We use a special vascular access area or a shunt. Usually we do this in the forearm. And this is going to remove fluid and waste products. And then we're going to return the dialysate or the solution specific to the patient's needs. This is an electrolyte solution. We're returning that into the patient's body. And this electrolyte solution or dialysate is very similar in the composition to the normal plasma. Again, because we need to cater to the patient's needs and requirements, we are going to have differences in the components of the dialysate. And the most common variable is going to be potassium. The average treatment can last 3 to 4 hours, sometimes even 6, and usually performed about 3 times a week. This procedure is going to be performed by a trained dialysis nurse and with also the education to the patient as well. So, what is the goal of hemodialysis in terms of nutritional therapy? We need to help maintain the nutritional status overall. We do not want excessive accumulation of waste products and fluids, and we're trying to minimize the metabolic effects of end stage renal disease. And the diet prescription is going to be individualized. You can see this example on table 18.2 in your book. And you are considering the kidney function, the dialysate components, how long the dialysis is going to occur, the rate of blood flow through the artificial kidney or the dialysis machine. Your meal plan will then be designed, monitored, and re-evaluated by the dietitian even before and after hemodialysis. The overall objective is to prevent, again, excessive accumulation of waste products and fluids. Remember, we're trying to minimize the effects of this disorder. So, what are the specific protein requirements for a patient on hemodialysis? Remember that we need to counteract the losses from dialysis, and there are going to be abnormalities in protein metabolism, altered albumin turnover, and increased amino acid degradation, inflammation, and infection with chronic kidney disease. So, the recommended protein intake for patients receiving hemodialysis is 1.2 grams of protein per kilo per day. And at least 50% of this dietary protein, again, needs to come from high biologic value proteins, right? So, animal sources. In terms of energy, we need to think about age and overall stature of the patient or weight composition. So, for adult patients younger than 60 years old, the daily energy intake is 35 kilocalories per kilo. Though with our obese individuals and any adult that's older than 60, there's a reduction to 30 kilocalories per kilo. In terms of fat, any patient receiving hemodialysis will be at risk for a lipid disorder. So, saturated fats need to be limited, trans fats need to be avoided altogether. And it's beneficial to supplement with the use of fish oils and olive oils. This can help reduce the damage from the inflammatory cytokines. In terms of sodium and fluid, these would be restricted but individualized because we're trying to manage the patient's weight gain between the dialysis procedures. Remember, they're having this done 3 times a week. You are going to monitor blood pressure and look and monitor residual renal function. So, foods that are going to be at a liquid state at room temperature, things like milk, creamer, and coffee, juices, soups, ice chips, and ice cubes, these all contain water. And these are things that we normally think about. But what about the foods that we don't really think about having fluid, but they do, like gelatin, pudding, ice cream? We also know that fruits and vegetables have a high percentage of water, specifically melons, grapes, apples, oranges, tomatoes, lettuce, and celery. So when we're thinking about the amount of fluid per day, we also need to count these foods as well. And then dietary potassium restrictions are going to vary depending on the patient's urine output. Our kidneys should be excreting any excess potassium, but this is going to be a challenge as the glomerular filtration rate declines, meaning that in the glomerular apparatus, the filtration is slowed down, and therefore not enough potassium is being excreted. Generally, 2.5 grams a day of potassium is going to be well tolerated by a patient with chronic kidney disease. But patients with anuria, meaning they're not producing urine, or patients with constipation are going to experience hyperkalemia because they're not filtering out these waste products, or for in this specific instance, potassium. Also, think of patients with insulin deficiencies, or if they have metabolic acidosis as well. These patients tend to be in a hypercatabolic state. Those that have beta blockers or aldosterone antagonists are going to have an even more stricter potassium restriction. These patients are usually those with hypertension. So the recommended fluid gain between each dialysis treatment should be less than 5% of the patient's dry weight. And dry weight means when they're not edematous. And then with this weight, the sodium and fluid restrictions will correspond as such. So fluid intake of over 1 liter per day, 2 to 4 grams a day of sodium, and 2 liters a day of fluid. Now, if they have a fluid output of less than a liter per day, then they will be limited to only 2 grams of sodium per day and 1 to 1.5 liters a day of fluid. Well, what about the patient that's not making urine? Then they are going to be limited to 2 grams of sodium a day and 1 liter a day of fluid. So it is really important as your nursing intervention to make sure that you are measuring their intake and output very carefully, as well as their dry weight. Now, that may have been a lot to follow. So, in addition to what you see on your PDF slides, I'm going to add the formulas here or the recommendations here on these slides so that you'll have them and you can write them in on your personal slides. Of course, we need to talk about phosphorus and calcium as well. And phosphorus is one of those electrolytes that are routinely restricted in patients with hemodialysis as part of their treatment plan. Because high serum levels of phosphorus contribute to secondary hyperparathyroidism, they raise then the calcium phosphorus products within the plasma. And although an intake of 12 milligrams per kilo a day is very typically recommended, you might need to restrict that even further, or they may be liberalized a little bit because we need to meet the protein needs of the patient. Foods that can be high in phosphorus, milk, milk products, cheese, beef liver, chocolate, nuts, and legumes are usually very, very limited. There are some medications that can be used to control phosphorus levels as well, and these are most commonly known as phosphate binders. These medications will bind phosphate to them and they are excreted, therefore limiting the amount of phosphorus that is flowing in the plasma. This phosphorus pyramid for renal patients, found on figure 18.3 in your book, is pretty helpful in terms of thinking about what types of foods you can use for patients that have a phosphorus restriction. And you can see that it's color coded red to green, red being the most restrictive, and green being the most beneficial or the ones that need to be consumed with more frequency. There's no restriction there at the bottom. And then you can see that fruits and vegetables must be used with caution in dialysis. Remember, we're talking about not only thinking about fluid as well, but also to avoid excessive potassium uh, levels. And you're looking to limit fats, especially in patients that are overweight or obese. We don't want to increase or cause excessive energy intake. And then for diabetic patients that also have chronic kidney disease, we're thinking about the limitations of sugar or carbs as well. Now, protein free products are shown for patients not on dialysis therapy and who need the protein restriction, but a high energy intake. When our kidneys are not working properly, then we may have decreased renal production of erythropoietin. And this is a powerful hormone that stimulates our bone marrow to produce red blood cells. An adequate availability of iron supply is necessary for normal erythropoiesis to take place. So we need to monitor iron levels. Supplementation of trace minerals is not necessary unless a deficiency is suspected or documented. So we need to monitor those levels first. So think about chromium, magnesium, and those other minerals. They have to be measured several times a year. If you do need to replace iron specifically, this can be given through oral supplementation or even IV iron, depending on the amount that needs to be replaced and how fast you need to replace it. Vitamin D is important in terms of renal failure because kidneys lose the ability to produce calcitriol, which is an endocrine function. Now, calcitriol is the active form of vitamin D. And there are many forms of vitamin D that are available in terms of supplements. But we need the active form, which is vitamin D3. And this is what's going to help prevent bone disease. Vitamin D3 is found in an oral form. We call this calcitriol, and can also be found in an IV form as well, and can be implemented during hemodialysis. Patients treated with hemodialysis are also at risk for water soluble vitamin deficiencies, specifically vitamin B6 and folic acid. Usually, it's because they're not taking in enough of these vitamins in their diet and they lose these nutrients during dialysis. Usually, the fat soluble vitamins like A, E, and K are not necessary. In fact, patients that are undergoing hemodialysis have been reported to experience vitamin A toxicity. So you do want to limit the intake of vitamin A. Now we're moving on to discuss peritoneal dialysis, which is the removal of the excess fluid and waste products from the blood, but instead of going through vascular access, we're going to be using the lining of the abdominal cavity or the peritoneum. So now the dialysate is going to be instilled and removed through catheter that is surgically placed into the peritoneal cavity. The dialysate contains dextrose, which increases the osmolality of the solution, and it's going to help facilitate the removal of any excess fluids. And as these fluids move from vascular space into the peritoneal cavity, the osmolality of the solutions are going to now become equal. Therefore, toxins and excess fluids are collected in the peritoneal area or peritoneal cavity. They're going to be drained through that surgically placed catheter and then removed. You might be wondering what the advantage is of peritoneal dialysis. And for most people, going 3 times a week to a dialysis center is really inconvenient. So, one of the advantages is that you can actually perform peritoneal dialysis at home. Intermittent peritoneal dialysis involves approximately 2 liters of dialysate over 20 to 30 minutes. Then the solution gets drained by gravity and then it's repeated again over an 8 to 10 hour period. An intermittent peritoneal dialysis can be mechanically performed or manually performed 4 to 5 times a week. And again, you're at home. Now, during this time, your patients are restricted to sitting in a chair or a bed. So it's not something that you want to use long term, but it is something that can help if you need to address the patient's kidney disease intermittently. If you look at figure 18.4 in the book, you can see some schematics showing you how the dialysate is used and how the catheter is placed, where it is in that peritoneal cavity. We also have continuous ambulatory peritoneal dialysis. And with continuous, we have the infusion of the dialysate that occurs over about 4 to 5 different exchanges in that peritoneum over 24 hours. And so there's a specific volume that's infused, and it sits there for about 4 hours, and we call that the dwelling time. And at the end, it's going to now contain waste and excess fluids that are going to be drained by gravity, and then another exchange will begin. The dialysate itself is present 24 hours per day in the peritoneum, except for that 20 to 30-minute exchange when the dwelling dialysate that's been sitting there for 4 hours is drained, and then now you have fresh dialysate being instilled. And this gets done continuously 7 days a week. It is a reasonable procedure for those patients that work outside of the house and can complete the procedure while even at work, right, because of the dwelling time. And then lastly, here we're going to talk about continuous cycling peritoneal dialysis. This is kind of a combination of both the intermittent and continuous. At night, there is a cycler, mechanical cycler, that's performing 3 exchanges. And then during the day, a 4th exchange is completed throughout the course of that day. Then at bedtime, the 4th exchange is drained, and then the process is then started over again. And although at night you're restricted to the bed, patients can move around during the day. They're not confined to a chair or the bed. So for those patients that are working, sometimes continuous cycling peritoneal dialysis is the way to go for them. The main objectives or goals of peritoneal dialysis is to maintain good nutritional status while you're replacing any of the proteins lost, specifically albumin, that gets lost with the exchange and the draining of the dialysate. Next, we want to also minimize any complications of fluid imbalances, and we want to also minimize the symptoms that can occur due to uremic toxicity, and we want to minimize any type of secondary metabolic disorder. So, just like hemodialysis, you have to treat patients at risk for deficiencies of water soluble vitamins. So, um, additionally to the water soluble vitamins, you are thinking about mineral supplementation. So, having a daily vitamin for your patients that includes folic acid and vitamin D are recommended. So, again, the goals of nutritional therapy. Additionally, patients may receive recombinant EPO, and this is to help correct any anemia that may take place. And we also prefer that they are on an iron supplement, and this is to maximize the effectiveness of the EPO. And remember, EPO is a hormone that is actually made in the body to stimulate red blood cell production. And so we're going to give a recombinant version of that to help stimulate production. Now, the energy requirements for patients that are treated with this type of dialysis, peritoneal dialysis, they usually um, require a little bit less energy than those that are on hemodialysis because 60% of the dialysate is absorbed. So the dextrose that remember we talked about earlier that's used in this dialysate, and we're using dextrose as an osmotic agent. And we're thinking about and we're taking into consideration that the energy needs are calculated um, specific to the patient, especially when the patient has diabetes as well. In terms of protein, the loss of protein ranges from 20 to 30 grams a day, slightly higher. Dietary protein recommendations are required due to this. And the serum B1 and creatinine is something that you're going to continue to monitor, as well as you're looking for any uremic symptoms, and we're watching the weight very carefully. These are all indicators of sufficient protein intake, and the diet has to be adjusted accordingly too. During dialysis, sodium potassium fluid are continually removed. So we are making very severe dietary restriction recommendations for this patient. And you're going to do this based on what you're seeing with your labs and with your dietitian. However, it's really important to remember that the nutrient needs vary among all patients. So it's always going to be individualized. So again, you're going to use the evidence of the assessment and the labs of your patient. You can also get some recommendations for like sodium tips and the guidelines through the University of San Francisco Medical Center. 2020 is the citation there. It is in your textbook. So there's a recommendation. I would look outside just to kind of peek and see what those recommendations are. And then in terms of dietary phosphorus, we also recommend restriction. It's very critical to prevent any development of osteodystrophy. Osteodystrophy is a term that we use for any defective bone development that can occur. And so, unfortunately, these higher protein requirements that are needed for peritoneal dialysis can then provide high amounts of phosphorus. And we are restricting or eliminating dairy products to control phosphorus intake. We don't want too much phosphorus. And it's usually going to be controlled by phosphate binders. So we give these phosphate binders. So instead of circulating through the bloodstream and then back into the systemic system, we are binding it to these phosphate binders and then they get eliminated. We're also going to recommend calcium supplementation as well. Then magnesium is another mineral that you are required to check uh, very regularly, and it inhibits vascular calcification. Thinking again, in terms of that term calcification, you're thinking about coronary artery calcification. It's really prevalent among dialysis patients. So, low serum magnesium is associated with increased cardiovascular mortality. With peritoneal dialysis, there's a lot of extensive training that goes into educating the patient and the caregiver. They need to be aware of signs of anorexia, nausea, vomiting, and the signs of uremia. And then also thinking about troubleshooting if they're feeling that there's inadequate dialysis that is occurring. So you're not getting the intention of the removal of the waste. Consequently, the nutritional status has to be monitored very carefully. And the National Kidney Foundation actually suggests regular and ongoing nutritional assessment. So it's not just one time the dietitian and the nutrition team assessing the patient, but this is a constant, ongoing um, requirement. So, some red flags: excessive weight gain. Um, every time you are visiting this patient, if you're doing home visits or every time they come in, you do want to make sure that you're not seeing any fluctuation or large fluctuations in weight. The absorption of glucose from peritoneal dialysate presents a special challenge when you have patients with diabetes. And so you're also thinking about their blood glucose levels, hyperlipidemia. It also becomes a little bit more difficult to control just because of the nature of the glucose requirement because of the osmolality that we need for peritoneal dialysis. Weight gain is often caused by the increased calorie load of the heavily dense glucose dialysate. Something else you're looking for is dehydration. That's a common concern because as we're removing excess fluid, we may cause extracellular fluid volume deficits. So, what are we monitoring? Blood glucose, I's and O's, and then weights as well. In the next few slides, we're going to be talking about renal transplantation or kidney transplant, thinking about pre-transplantation now. So before the transplantation actually occurs, we already know that the nutritional status is going to be really important to correct if there's any deficiencies, especially before surgery. We want to optimize the outcome as best possible. And poor nutritional status can be caused by a myriad of things: protein, blood, nutrient loss that occurs during dialysis, catabolism due to the chronic illness that they have can also cause a poor nutritional status, as well as the depression from chronic illness. Anorexia, altered taste, doesn't make you want to eat when you don't really taste things correctly. Also, decreased visceral protein stores and body weight are very common. The deficiencies of vitamin B6, folic acid, vitamin C and D, and iron, these are very common as well. So, the nutritional therapy and the plan for replacement is going to require an individual approach that you can see as a common thread with all the renal type diseases and disorders. Okay, so now we're talking about immediately after the transplant has occurred and then long term nutritional goals. The energy needs immediately after transplant are really high, like 30 to 35 kilocalories per kilogram. And this is because of the stress from surgery and also the catabolism that is occurring. So, about 6 to 8 weeks out, the requirements are going to start to lessen. And then intake then needs to be based on a desirable body weight and how to maintain and then or achieve and then maintain that body weight. So there will be restrictions of dietary protein that used to be necessary, may not be necessary again. So let me say that again. Restriction of dietary protein is no longer necessary about 6 to 8 weeks out. In fact, protein catabolism increases as a result of the surgery and because your patient is going to be prescribed corticosteroids for immunosuppression to keep that transplanted kidney happy in the new body. Steroid therapy can cause, now if you're thinking about the corticosteroids, it can cause glucose intolerance. And therefore, because of that, now we need to really tightly control the total amount of carb intake or the carbohydrates. And then you think about the complexity of maybe a diabetic patient as well. It's often complicated by worsening new onset diabetes. And there's a lot of studies out there, a lot of anecdotal stories too about transplant patients where they may not have had diabetes. There may be other reasons why they required a kidney transplant, and now they have new onset diabetes. Because of this, and we need to think about the diabetic needs. Saturated fats are going to be limited because of the risk of dyslipidemia. We need to encourage omega-3 fatty acids, and then this hopefully will improve plasma lipid patterns and decrease any type of systemic inflammation. Generally, fluids are going to be unrestricted, and um, many drugs after transplantation influence the nutritional needs and the status. And how their patient is doing overall is going to kind of tie back into what the fluid needs may be, but generally unrestricted. Think about sodium and potassium. Again, this is going to be individualized for the patient, especially if they have hypertension. And so you're thinking about all the comorbidities that they have or they don't have. So it's hard to give a blanket statement of what you should be doing at this point with the electrolytes, case by case, individualized, working on labs and patient presentation to give you more insight there. They will be closely monitored by a dietitian at this point as well. And then I just wanted to show you, I thought this was pretty interesting in your textbook. All the different things that are contributing to the hypertension after a kidney transplant. So they may, I'm starting from the bottom there, they may or may not have already had hypertension. They may or may not have already had left ventricular hypertrophy. So now this is going to feed into worsening hypertension. It may be a graft dysfunction. It could also be a renal artery stenosis that's causing it. There's donor factors. Maybe there is donor hypertension or vascular disease of the donor kidney. And then just thinking about the age of the donor, the immunosuppressants that are given, like the corticosteroids, and then there could be outflow obstructions too. So you're always looking for reasons why it could be a post-kidney assault or post-kidney issue. Okay, and then the last part, but pretty interesting, is the kidney stones or renal calculi. And these are very common, actually, especially in older adults, or more common in men than women. Half of those patients that have renal calculi or kidney stones, they will get them again within the first 10 years. And it's really important that this ongoing nutritional education is provided and checked in with because the uh, incidence is so high. In patients that live in very hot climates, they actually have a higher risk for kidney disease. And then for children, especially too, if they live in hot climates, if they have any cause for dehydration like diarrhea or infection, their children are more at risk. Or it could be an anatomic abnormality with their urologic system that puts them at risk for kidney stones. So different causes, but something really important to remember is that most stones, at least 60 to 70%, are composed of calcium oxalate. So that's going to be the highest. Your patho book may give another percentage as well as your med-surg book, but know that calcium oxalate stones are going to be the most common. Only less than 10% are struvite stones, 10% are uric acid stones, and only 1% are cysteine stones. And this is important because you are going to educate in terms of dietary goals based on the composition of the stone. You can see here on the slide the many contributing factors that can cause the formation of a kidney stone. Low urine output, not enough water, also having a very high urine pH or very alkaline urine. Also, if you don't have enough calcium oxalate, or excuse me, if you have too much calcium oxalate uric acid or a combination of those things, this will increase your risk because, again, look at the components of those. Those are what the stones are made of. And then also, if you don't have enough of the substances in the urine that inhibit the stone from forming in the first place, you're going to be high risk. So there are dietary recommendations for patients with kidney stones or patients that are at higher risk. Remember that if you've had one, you're probably going to have another. And we really are tailoring this diet to specific metabolic disturbances of that patient or their individual dietary habits. The first thing we want to think about is fluid, generous fluid intake. You want your body to make at least 2 liters of urine a day. So, in order to do that, your patient needs to take at least 2 to 3 liters of water a day. You want to avoid severe dietary calcium restrictions, however. So, you want your patient to consume calcium rich foods instead of taking in supplements. We want the calcium coming from food. We want to limit oxalate. So, what are those things that have oxalate in them? Spinach, rhubarb, beets, chocolate, some nuts, tea, wheat bran, and strawberries. So many times patients that have oxalate stones or calcium oxalate stones, they won't be able to drink coffee and tea, eat chocolate. We are limiting supplements from vitamin C and D um, to only the recommended dietary allowance, or the RDA, for their gender and age. So we don't want an excess of that. So you're monitoring that pretty closely. We prefer plant-based proteins over animal proteins several times a week for these patients, limiting their salt. Uh, 5 or more servings of fruits and vegetables a day for potassium sources is also what is recommended. Too much calcium in the urine, this is called hypercalciuria. It's probably the most common cause of people that have calcium stones. And the stone formation itself is then influenced by oxalate, and more so oxalate than the calcium. We just talked about oxalate and the different foods, but primarily these foods are deriving from a plant origin, and then the end product of ascorbic acid metabolism. So, restriction of oxalate is encouraged. You can see here that the nutrition therapy to protect against calcium stone development is 800 to 1200 milligrams needed, combined by a restricted animal protein and sodium diet. So, again, remember, we want more plant based proteins for these patients. Talked about the high intake of fruits and vegetables, and we want to balance that with low fat dairy products. This is going to carry the lowest risk for kidney stones. It's also important, again, only use the RDA for calcium and vitamin D, so no excess of those supplements. Low intake of potassium is another risk factor. So many times, this may get supplemented. Potassium reduces urinary calcium excretion to kind of counteracts, because it's going to cause transient sodium diuresis, therefore increasing renal phosphate absorption. So diets that are high in potassium and lower in animal protein are going to help with the prevention of these calcium oxalate stones. So if you think about what type of diets out there that may help patients that are at higher risk for calcium oxalate stones, it would be the Mediterranean diet. For uric acid stones, um, remember that uric acid is a byproduct or metabolic product of purine metabolism, and this is a nitrogen containing compound. Uric acid stones are associated with acidic urine. So those that have a lot of acidity, and also patients that have gout are going to be more at risk for uric acid stones just because of the high levels of um, uric acid that their body is producing. So additionally, like if you have a patient that has a lot of gout flare-ups, I'm also asking questions about symptoms of stone development as well. So, urologic symptoms. So, patients on gout are usually going to be prescribed allopurinol or a similar agent. It helps to reduce high levels of uric acid. And by doing that, you're also going to reduce your risk for uric acid kidney stones. However, the key therapy is weight loss. So, a balanced vegetarian diet with dairy products seems to be the most protective type of diet for patients that are more susceptible for uric acid stones. So, we do want to, again, increase fluid intake 2 to 3 liters a day. We want to alkalinize their urine. So, we're going to have potassium citrate as supplements and promoting lots of vegetables. With patients with cystine stones, these are from it's from a hereditary disorder, most likely causing the stone to excrete too much of this amino acid cysteine into your urine, so cystinuria. And the goal is to reduce this urinary cysteine concentration. So to do this, we need the urine volume to be greater than the 3 liters a day. Remember, for most stones, the calcium oxalate stones, we're only gunning for 2, but for this, we need at least 3. And then the urine should be alkalinized to pH in the range of 6.5 to 7. And we're trying to restrict animal proteins and sodium, and this will also help reduce the cysteine production. And then lastly, now we have the struvite stones. These are caused by urinary tract infection. So someone that has repeat urinary tract infections are going to be at higher risk for struvite stones. And this is because bacteria splits urea into ammonium in the urine. There isn't really a specific diet for this. It's actually just don't get dehydrated and addressing any risk factors of repeat urinary tract infection.